We are live.
Yeah. Good morning to all, and I welcome all the participants to the 71st SCFI Roundtable Expert Group meeting. Today, before I speak further, today is the 14th August, and tomorrow we are India is celebrating the 75th Independence Day. So congratulations to all in advance for the 75th Independence Day tomorrow. And topic today again remain is a continuation of the what we discussed last time, the role of AI in general for patient care as well as in COVID-like situations. Today, Dr. Sunila Garg is not going to join. I will request Dr. Arun Agarwal. He is there. Sir, sir, you will be.
Yes, Dr. Kalra.
Yeah, we missed you last two sessions.
Yes.
And I will request you to chair today's session. And before I hand over to you, I will like to just give in 2 minutes a update on the COVID situation as on date, and then I will hand over to you, sir.
Thank you.
So let me share screen. Saurabh?
You can share.
I think this is visible to all. Yeah.
Yes.
So if we see the COVID situation for the last almost 6 weeks, situation is a little bit stabilized, but it's not declining also. And almost 38 to 40,000 new cases per day we are seeing in India. And if we see the globally also the trend, you see the just graph globally also compared to the last week, and there is a slight upward trends. And India is just, as I earlier said, around 7 to 8 weeks. It is controlled around 38 to 40,000 new cases a day. Maharashtra and the rest of the states in India, except the Kerala is still keeping finger crossed. Around 22,000 cases per day are being contributed by the Kerala state alone. Karnataka is now settling down, and rest of the Tamil Nadu, Andhra also, rest of the country except the Kerala seems to be settling down. And Delhi also for the last 1 week between 50 and 60 cases a day. And if you see the global situation as per WHO weekly report, in the last week compared to the prior week, globally there is a 4% increase in the cases, as well as deaths also. There's a 2% increase in deaths across the world. And as per WHO regions, last week the cases were contributed maximum by the region of Americas, and then it was Western Pacific region countries. So Americas region contributed 14%, and deaths have decreased by 4% in that region. And in Western Pacific, 19% increase in the number of cases, and 46% deaths have been noted. So the country level, the highest number of new cases were reported from the United States of America. This week, around 7.34 lakhs, which are 35% increase compared to the prior week. India again has shown overall in the country a 2% decrease compared to the last week. And Iran, 20% increase, Brazil, 8% decrease. Indonesia, again, has this time has shown 18% decrease in the new cases. And as per one report in the media, in Maharashtra state, overall 66 cases of Delta plus variant has been reported, and Delta plus, this variant has caused 5 deaths in Maharashtra state. So vaccinations given in India as on date are 53.61 crores. So this was about the COVID situation update. Now I hand over to Dr. Agarwal. Dr. Arun Agarwal ji, please continue the session now.
Yes, thank you, Dr. Kalra. Before I start the real session, the only worry is Kerala.
Yes.
Where the numbers are, Professor Bijay Mishra, are continuously being around 20,000.
20,000, yeah.
You see, 20,000 in Kerala means, if I say if there are 20,000 cases in Kerala, that means in India should have 5 lakhs new cases. I mean, why it is happening, we are not able to understand. It's a worrisome status.
Yes.
I mean, thoda bota, if there is little increase, it's okay. But anyhow, that is one worry. And just yesterday, I was inquiring for the information of my colleagues in some of the big corporate hospital like Apollo or Max. And for last 7 days, there is not a single new case entry. So that not only reflects Delhi, that reflects practically a big zone of North India. Dr. Kalra, what I'm trying to say, otherwise, if there is a fresh crop, these few hospitals gets reflected because of the reference.
Yes.
So that is a plus point. So with this remark, today we are going to talk something which is already very challenging. And before I joined this session, I was just spending little time in, I am very fond of WION channel. And WION channel was just now covering the status of startups in India. And Dr. Arun Jamkar also mentioned that 10% patents are medical. So this is one field which is perhaps India is taking lead, and that is the lead, that is the topic of artificial intelligence with various applications. And our expert speaker is our own, and very especially for me, my own Hamnam, Dr. Arun Jamkar. So we will request him to start, and then we will like to learn something from him, and then we will go for active discussion.
Thank you, Dr. Agarwal. Dr. Kalra, what I was suggesting, you give your COVID status. There will be some small talk, or maybe five minutes addition about the therapeutic status of present management, because everything is changing so much.
Yes, sure. And next week, we will do that. Sure.
So
that is very important. The therapeutic status.
Yes.
Changing trend.
Changing trends, because everything is changing so fast.
Yeah.
Now I'll just share my screen. Is it seen?
Yes.
Yes. Your sound is not coming.
Okay, is sound there?
Yeah, now it's there.
Now, last time I just talked about, wait a minute. I just talk about how AI is affecting all fields of medicine. And I gave a lot of insight about what is AI and say different models of AI and variables. And then in fact, I gave little details about whole concept of AI with ML and all those technologies and types of emails, and then supervised learning, unsupervised learning. And one of the big, all those things have been already taken care. And one of the biggest thing that we are having is image handling, because the maximum number of say uses is in image handling. So image handling, then I gave some examples. Say image handling has been used in diagnosing skin diseases. In fact, there is one company called FirstDerm, where you have to just upload an image of the skin disease and then they give diagnosis. And I think this is all on AI. And diabetic retinopathy is also being used very often. And I think the details getting strength, and then FDA has already approved the preventive management by say screening say diabetic retinopathy. Then I talk about mammography, where one of the biggest success stories are there. Now then similar thing, we have something about digital pathology. And I think actually digital pathology was approved by FDA before, but then they were behind. Now there's something happening is big, is instead of digital pathology, everybody knows about because it's simple and to diagnose and then compare. And there's something called as 3D imaging. So instead of sending a slide, you can just directly send a tissue, and then they will take a 3D, say what you call it as imaging of whole thing, and then it can go beyond the sections. I think this is one of the biggest discoveries. I'm not going to talk in much detail about this. And then nowadays, all these things are available in theater itself, where a tissue can be given. Are you able to listen to the sound? Dr. Kalra?
Yes, yes.
और साउंड नहीं सुनाई दे रही है.
एक मिनट.
मेरे को तो आ रही है.
Dr. Kalra, he's talking about the video sound.
Video sound.
Video sound was not coming.
Video sound नहीं, हाँ.
When you're sharing the screen, नीचे को sound share sound का है.
आ गया sound?
Yes.
Now this is wonderful that you have a tissue available in the theater. You take as a biopsy, and where you have to wait for 15 to 20 minutes to half an hour. Now that whole tissue can be uploaded in the theater itself, and the diagnosis would come, and then whole image would be there to discuss. I think this is some of the wonderful things which will change whole management. Okay, let us go ahead. I was talking about radiology. Now these are the various platforms available, and these all platforms are available for free. And now TensorFlow is by Google, And then the people can develop AI-based systems diagnosis of image handling by TensorFlow. I was just giving one talk to one of the college, and then there was one student who talked about that, and then he wanted to do something. He wanted images of
yeah. आज मैं
chest.
आ सकता हूँ, जरा diffraction check कराना है. शाम को कितने बजे?
Hello,
Around 6. Okay.
am I audible?
क्या जाऊँगा मैं? ठीक है, ठीक है.
Okay.
Dr. Kalra, can you mute yourself?
अच्छा, सामने ही है ना? अच्छा, ठीक है.
So
बोर्ड लगा हुआ
I
है.
was just trying to help him out.
ठीक है, मैं वही.
Then he developed that whole model based on TensorFlow. And then I was just giving him all the data of X-ray chest and everything. And then I asked him, what are you doing? Are you for getting some, did you pass to B, or are you joining some startup? To my surprise, that guy said, I am doing 12th standard. And this was for getting admission in good American college. So I think so much has penetration of this technology is gone. I'm not going to fail. And Siemens is coming with big way with all these radiology diagnosis, but these are the various levels where image handling is being used. Say X-ray chest, detection of lung nodule, detection of pneumonia, detection of vertebral fractures, then CT scan, CT angio, MR angio, everywhere we have all these technology available. And if you can see, now this is the frontal X-ray and the lateral X-ray, then you have output, and then all these diagnoses are available. All these diagnoses are available. And they are reasonably better than even X-ray, say radiologist. If you can sit down, average is 0.69, whereas the dual net is 0.721. And the best part of the story is most of the X-ray chest, they are normal, and the normal X-ray chest is 100% reported better by AI system. So these are the various what you call as databases of X-ray chest. I'm not just giving you some details, and these are the various diagnoses which can be done with AI system. These are for MRI. I think same level of competence is there with the AI system. And then we have something called as Chester, the AI radiology assistant. Everywhere, these are one of the success stories of medical imaging. Now one of the things that we can detect, say, rely upon is in coronary angiography. And now with the coronary CT angiography, I think say cardiologist can more rely on AI system than on the radiologist. And now these are the various papers where they say they are evaluating the AI system, and these are the, say, deeper layers and hidden layers and everything going on. Then I talk about corona last time. I'm not going to say anything more. In epidemiology, I talk about how the blue dot is doing. Then drug discovery, I just talked last time. And then
one day
called Bacitinib. And if you can see the present status of Bacitinib, the beauty of Baricitinib is it has been entirely identified by AI system, going through thousands of molecules for repurposing drug. I know that this is the present status, that Remdesivir with Baricitinib is one of the best combination for, say, patients in ICU. Then we talk about ICU, how the AI system can correlate with networking of all the ventilators, and this can lead to going all this management to the say level of a rural area. The vaccine we talk. Then we were coming to how it is developing for the clinical management, and I talk about cytokine storm. And now I did my PhD in interleukins and interferons long time back, and then I had varied say, vivid, fascinating study about interleukins. And when the moment I read about cytokine storm getting through the IL-6, and then I thought we should use an IL-6, monoclonal antibody called tocilizumab, which has been presently used. And I wrote everywhere, including BMJ, and nobody published. That's why at the end, I put it on LinkedIn, that how the tocilizumab could be used in managing cytokine storm. Maybe there might be multiple intelligent nodes across the world, and they started using. Now we are into monoclonal antibodies, and there are several monoclonal antibodies are coming. And then these are the two which have been given the clearance by FDA. Casirivimab plus satrozumab intravenous infusion is giving better results. At the same time, the people were using bamlanivimab plus italasivimab, and then FDA has said that this doesn't give any better result. So I think that's why I was suggesting in our talk, we should use the latest therapeutic status of all these. So we could go through AI systems to find out exactly what is the state of each of these drugs and how it is exactly going. And Dr. Kalra, this is a very interesting platform called COVID-19 Research Explorer. Now, you just click it there, and you could go to any of the latest studies about the COVID. I think this is which we can do. There's something called as a COVID scholar as well. And this is all the success stories of AI in the cancer that IBM Watson is being used in oncology. Then Boughton et al. Develop AI system to restore in quadriplegia. Then there's various, these are the success stories of AI system to identify how can we treat. So my suggestion is, there has been a tremendous development going on in these areas, and we are not able to utilize our own experiences and success stories. And therefore, what I suggested was we could have a cluster-based analysis depending on clinical picture, radiology, hormone status, cytokine status. The hormone status could be the serum ferritin, procalcitonin, pro-BNB, interleukin-6. And then suppose we put them together and then put them into what you call as an unsupervised learning in a, say, machine learning. It will give you the clusters. And then we could find out what are those clinical clusters and identify what we are doing with intervention. Now, these interventions would from AI system. Where we have a cognitive domain analysis, and then we monitor these patients and find out what are the success, what is happening to the treatment protocols, and then find out the outcomes, morbidity, mortality, survival rate, and quality of life. And this could go again back with a supervised learning to the interventions so that this learns. And therefore, the moment we do come into this loop, because we are just identifying the real-time management, we'll get latest management protocol which has been used and which are more successful. So I think I don't know whether anybody in the world is working on this, but this is my model which would improve the status and management of COVID. So what is required for India is network all clinical data across the globe, using database handling models and crystallize the data, cognitive domain analysis of infodemic, and then real-time dynamic outcome of all these interventions. Now, the advantage is sometimes there might be some micro successes where they can't be reported, but then this could come into this platform and these micro successes could be identified. And all these, based on AI, we could extrapolate these micro successes in spite of small sample size. And then it would be available for all clinical establishments across the globe. And it will help a clinician to make a mature opinion. Now, the disadvantage in India is usually most of the patients are being treated in public sector, and they don't have what you call as EMR and ESR systems. So I had suggested that all the case records of patients treated in these hospitals should be digitalized, so that once you digitize, this could be available for say continuous monitoring of these patients. Now, AI has been used in all these manners: early detection, diagnosis of infection, monitoring, contact tracing, then projection of cases of mortality, and development of drug. Now, there's something very peculiar has happened. Now, you can just get a cough sample of a patient in front of app. So just ask your patient to cough. And then depending on that cough, somebody has created a algorithm on AI where just on a coughing sample in front of that app, they were able to diagnose COVID. This has to be, this has already validated. I think that's one of the things which is one of the successes which need to be followed. Then people were coming in big way, and we don't want to contact, and then AI was used for face recognition instead of giving in a thumbprint. At the end, I just want to talk about the eye doctor, what's the drug dispensing ATM, which is based on symptom-based algorithm. As I told you, it has 3 parts. So it's an attempt to go beyond current telemedicine model and support Indian citizens to get affordable healthcare within their vicinity. So we have 3 parts: a kiosk, algorithms, and dispensing. In a kiosk, where the patient sits in front, and then because we want to have what you call as personalized data, and it has to be made safe, everybody has to enter, say all the patients and all citizens. Suppose we are putting that kiosk in a village, so one doctor has to go through the patient record and examine everybody, and then enter the data in the kiosk. And then once he comes, he has to come with Aadhaar card and then fingerprint, and then it will be validated. And then it goes into say all those questions. And before he starts, we take with the point of care devices, his blood pressure, his pulse oximeter, his respiration, and all those 6 details. And then anything abnormal, we have created a loop by which an ambulance can be called. Then he sits in front and talks about symptoms. And because it's only on the symptoms, it asks you all those too many questions. And then it gives you a diagnosis. And at the end, the machine which is attached directly dispenses the drug. So these are the components: biometric authentication, weighing, thermometer, oximeter, blood pressure, ECG. We could have a camera, and then the questionnaire and the drugs. So this is a symptomatic treatment. There are a lot of limitations. So we need to find out the allergies, identification of the patient's criticality. But then best part of the story, there is the geotagging. So suppose at the end, through the symptoms, we diagnose something as malaria. We could be able to identify and do an say endemicity of that whole thing. And suppose we are 250,000 gram panchayats. Suppose we put all these, then we could may be able to map everything, and it can support a healthcare policymaker. So just going into detail: registration and then diagnostic process. I'm just going to call and give you a little detail. They collect the vitals. Then if it is beyond limit, call ambulance. Then major health related issues. Then also referral, and then check hospitalization, and then check duration. And then this whole thing will find out that if anywhere we have red flag questions.
Please finish in 5 minutes.
Okay, we can go into details.
We can have time for interaction. Yeah.
Okay. So I will just go into, I think I will just skip all these because I talk of all these, and this is all what you called as points. This will look like this, all those, because this has made simple, and all these eye doctor, These are the snapshots. And at the end, I just wanted to talk about home care, or maybe it could be used by an Anganwadi worker or all home care assistants, where we can have a tab where all the data is available through the cloud, and then it has point of care devices. What you want is we can create a sort of Ola model that we could have regional centers in every area where the home care assistant can go or an Anganwadi worker can go. And then the tablet will have all those point of care devices which eye doctor has. And then it will be improving a management directly under supervision of the physician sitting in that center. So this is what is called as, we call them health mon. And this was a model which we created for public health, where it could be say public primary health center and regional health, say regional centers. So everywhere it can go up, and then the whole data is available to DHO and district hospitals. So this is a model which can again improve the quality of healthcare in the maybe urban area or the rural area. Thank you.
I think before I start my comment, after listening to Professor Jamkar, I will request all my colleagues to give him a big clap.
Thank you. Thank you.
Dr. Jamkar, the way you have collected your thoughts, put your mind into it, and your technical expertise, it seems that the whole of the medical scenario is changing so fast. Dr. Kalra, do you remember there was a serial Star Trek around 20 years back? I recollect that serial, and what I feel, it seems that perhaps in near future, the patient will walk in front of you and you will be able to diagnose with the 3D camera and 3D microscope with you, and perhaps you will come to the diagnosis.
Dr. Agarwal, there is a movie called Passenger.
Yes.
Which has an aircraft traveling for 100 years. And there is something called as Autodoc. Actually, I usually show that movie because of short of time. That is what is the future of medicine.
Yes. What I mean to say, the 3D printing of the histopathological sample, which has become a reality now. And you correctly said that whatever is the technology, my first question to you is that what is the ultimate, how much India is contributing in development of such technologies?
I think we contribute tremendously. Basically, we being cost effective in technology.
Yes.
Now I work with Persistent Systems, and maybe more than 1,000 various industries in US. We are helping them to develop their technology. Now to tell you, I have a lot of limitations about NDA. Now we are developing in software for a total knee replacement with a robotic technology. And we are giving it to one company which is into what is called as a 3D prosthesis. So taking all the images of MRI, you can develop an exact prosthesis for that man, which is customized. And it being a 3D, it is porous. And therefore the Haversian canals and all those canals can go inside, and then it will develop as a part of bone. And this whole thing is being done here, where every software and everything we are giving to America.
Want to add
compliment? You are talking about the 3D customized implants.
Yeah.
In relation to bone or in relation to
can I, Dr. Agarwal, can I comment? Yes.
Yes, yes.
Yeah,
Ashokji,
I mean, thank
please.
you. Thank you very much. Thank you, Dr. Jamkar. Wonderful presentation. And 3D printing and 3D custom-made implants and become a reality. I mean, 20 years back, I used to struggle in develop on some of the facial implants, which now has become a reality. We have to send the 3D data and then the complete thing is sent. So I think AI has got a definite role to play in our scientific advancement. And also about one point I want to share, Dr. Srinath Reddy, through his Public Health Foundation of India, had developed a SWAS Slate, which was actually digital screening of all the NCDs across the country. And it was a very successful model, which I was also involved in some of the development. And I think is a great requirement, a need of the time in our country with such a vast rural base to develop a rural screening model for NCDs, and that will also give us a statistics data and other parameters to plan for our national policies more effectively. And I think of course, eye doctor is a mandatory part, is something which is welcome. But before the eye doctor, and I was shared that the government of Maharashtra, at least, they have, and some of the other states have allocated 15,000 rupees to ASHA workers for the purchase of a smartphone. So holding a smartphone with all these gadgets and all this software has become a reality, and we can definitely push this rural screening for NCD as a ground reality and ground need for the country. Thank you.
And what use for use of this eye doctor, because we have all those algorithms. We could made it for plastic surgeon, for a cardiologist, for a urologist. And then while the patient is waiting in your waiting room for his appointment, you could just go through all that and fill in the algorithm. And then the doctor inside will get directly that data, so that he can spare all that time and he can talk better and he can treat better. I think these are the various models. It could be used in a busy OPD where 10 machines could be used. And then the doctor sitting in OPD can can spare all that time for management.
Thank you.
Dr. Jamkar, 1 minute, Dr. Jamkar. Have you studied that model by Rajasthan state government? They have given some tablets to the ASHA worker for some MCH program. Are you aware about that?
Yeah, same model.
So how efficiently they are able to use that? Is it useful, replicable?
We have 3 problems. 1, internet connectivity. 2nd, electricity. And 3rd is literacy. So our models don't work because there's no internet, no electricity.
So it comes to this.
Same, yeah. All AI models are based on internet connectivity.
It is cloud-based. Yeah. And in spite of all the development, we don't have better internet even in urban area.
Yeah.
Actually, we have overcome this problem by 2 ways. One is a data stored offline, and it is shared only whenever they go online. And second is a solar cell attached to the tablet or a handheld device, so that the electricity problem is taken care. Yeah. The solar recharging of the battery.
So, Dr. Agarwal, can I come in?
Yes, please.
Yeah, so this is a continuation of last week's conversation which you have had, and I think you were not present, so you may not be aware in terms of the issue which I had raised. And the major issue is some of it just got discussed now, that you can talk of technology, but technology has to become an enabler to ensure that the patient at the end of the day gets the best value out of the technology. If I don't get that value, you can talk about technology for 100 years, but it has no value to me. Because as you know, and I would like to correct a bit of a data for India, 80% of the patients are accessing private sector healthcare in our country. Vis-a-vis, only 20% are going to the public healthcare system. Now, the first thing is the private sector has to understand how they can reach out to the remotest part of the country. And that is why the Ayushman Bharat concept was brought in, where we fought, vigorously to convince the government that they should allow PPP at the health and wellness centers. You will be surprised to know that in the health and wellness centers, not a single private sector has come forward to partner with the government to work together to bring in such technologies in a manner that it is made accessible to the citizens. And we are still struggling to understand. And as you very rightly said, many of you, without electricity, without a broadband connectivity, how is the technology going to help you? I am in Hyderabad these days, and even at a developed place, I find service providers not able to give the bandwidth in the manner it is required. So you see how you forget about rural. You talk about urban, you're not getting it there. So my contention is, first thing everybody should call for and ask for is a good, strong infrastructural facility. Till that doesn't come, this technology of AI and other things which we are discussing is good for those countries who have the infrastructure. And they now want to reach out to India because they are presuming that we have the infrastructure. So first, let's build the infrastructure in the interest of the patients, which is completely missing, completely missing. Several studies have revealed that we need to strengthen the primary health centers, the ASHAs and others, not only by giving tablets. Tablets doesn't help. The tablet has to be made functional. And this is where I would like, our expert group to formalize a kind of a strategy, that how do we go about formalizing that strategy to strengthen the infrastructure, for which government is all the time talking about, having resources. Do you all know that there is something called Universal Service Obligation Fund? You pay 10% of your telecom bill every month towards that fund. And that fund is supposed to be used for building telecom infrastructure. And you will be surprised to know that 80% of that fund is still lying unutilized. But you pay every month 10% from your bill. But you never demand that why this 10% is being taken when you are not able to utilize that money, which we are paying knowingly or unknowingly. So the USO fund should be used for such purpose. And that should be the demand which should go from this expert group to the policymakers. I would like to stop here. Thank you. And Chairperson, I would like to be excused. I would like to be excused because I have to go to another meeting urgently.
Okay, but
I will get some answers from Dr. Arun to my questions of last week, but maybe it will be kept one-to-one. We may keep answering offline on issues.
Professor Mishra, I will hold you for 30 seconds. In continuation of what you have mentioned, I agree with you that the slogan of medical fraternity, we should not do any harm to the patient. Right? So whatever technology we are adopting, that has to be adopted in the best benefit of that patient. Number one. Number two, we have to remember that as compared to many countries all over the globe, in India, there is one thing in abundance, and that is the woman manpower. Right? Rather keeping that woman manpower away, you are trying to bring practically a negative wave, because otherwise the employment of various kinds get jeopardized. And number three, yes, all the new technologies are most welcome, but I think it has to be a combination of technology and, as we always say, touch. The two T important, that there has to be a touch, there has to be technology, and then the best outcome for the patient.
Thank you.
I will get your email and maybe have a Zoom talk with you, Dr. Mishra.
Yeah, thank you. Thank you very much. So, Chairperson, can I be excused
today?
Thank
you. Thank you. All the best.
Arun, can I come in for a minute? Arun,
yes.
Yeah, I think Professor Arun, excellent presentation. I think technology has come to stay, and I think I'll focus on one sentence that you said. I said that you said that we have to use the gains of technology and use it. I think you said while use the time that the doctor saves. I think that's very crucial in this time of artificial intelligence, in this time of technology. As Arun also said, I think empathy, compassion, and touch are very important. And I think there has to be a balance between both. Otherwise, just purely focusing on technology is not going to help. We need to use technology. We need to use artificial intelligence to ensure that quality, affordable healthcare is affordable to all. But we should also keep in mind that we need to spend more time with the patient and communicate with the patient and his family. I think that's a very, very crucial part of what we do. Thank you.
Great. Yes.
I just wanted to answer something that
Yes.
Dr. Earlier speaker said about healthcare infrastructure. And one thing I want to drive your attention, now we had been successfully using ASHA workers for controlling epidemics and giving a primary health care. And all these ladies, they are paid less than 10,000 rupees per month. And your even say housemaid gets more salary.
Yes.
So government has to do something in long term, and then the budget of the public health is in say 10,000 and 20,000 crores. So I think we need to give some maybe a brainstorming decision that the remuneration has to be say to what you call it as address the needs and whatever the duties they are doing for the public health.
This is the greatest
But-
bottleneck for the public health program, because everything is dependent on the ASHA workers. And ASHA workers are even being paid less than 5,000. You're absolutely right.
But the basic policy, Dr. Kalra, ASHA worker will be paid depending upon the performance and incentivization.
Yes.
If I'm not wrong, there are certain places where our ASHA workers are definitely getting more money because of their dedication and the outcome-based parameters, whatever has been decided. But I fully agree, they are so less paid that there is always a unified unsatisfaction in that particular group all over the country.
Actually, there has been a strike by ASHA workers across the country.
Yeah,
For
Many
the
times.
increase in remuneration, and I think, and that's completely that they must be paid. In fact, one of the trial which we did with the Swasthlet in Maharashtra, and we could increase their patient cover by almost 20% or 30%, and the government accordingly increased their wages for that particular month because we increased the number. I endorse, and I also support Dr. Alak's statement. There was a first World Conference on AI in Dubai about 2 years back, and this was a very big discussion on that. And at the close of the session conference, the message was that AI is something which is very extremely welcome in medical teaching and medical treatment, but it cannot replace the expert and experienced fingers and expert eye, and it has to be again with the empathy and touch of the patient is very vital, which cannot be compensated by AI, role of AI in medical education at least. And I think that's very important. Medical education still needs some of the highly experienced and dedicated teachers rather than relying entirely on AI, because the error factor is still there in the AI. I mean, we have been using this in ICU, Burns ICU. That was the world's first Burns ICU was made in Oman. I was member of the team of that. And we could get the same quality of treatment for all burns patients across Oman by sitting and controlling everything from the Khala hospital in Muscat, Oman. So that the standard of care of burns patient across Oman is same. And it is all can be controlled because the centralized ICU of burns ICU in Oman. I think this is a very great role to play, but it has to be used very judiciously in our country.
We honestly declare that AI systems or all these technology can never replace doctors.
That's right.
Assist. Let us say we are talking about AI system for X-ray chest. If a radiologist is able to screen 50 X-rays, maybe 20 X-rays per hour, he will be able to do 40 X-rays per hour.
Yes.
Yes.
And the costing will be reduced. And the biggest advantage that we have in not exploiting is a number of investigation that we do. The population has suddenly become a strength. Now I know one company called Krishna. They do 10,000 X-rays per day and maybe 500 to 1,000 MRI and CT scan per day. So such a data, because all AI will depend on data. If you have more data, that becomes more confident and say more competent. So I think we need to pass on this message that all these population of patients and the data can be used for AI.
Yes, I think, can we see comment of Dr. Roy? Dr. Roy?
Sir, thank you very much, sir.
Chup
Am I-
बैठे हुए।
No, man, it was so interesting information. Really, we are surprised and we are feeling very happy that artificial intelligence is going to replace the senior most consultants also. And one thing more,
language में sarcasm है।
No, sir, I'm sorry. I will quote one thing. At some place I was asked to speak something about the family physician and for the medical profession, how it is changing. I will take only 2 minutes. I just started. A time was there when there was only doctor and a patient. There was no in between them. And those patient and doctors were having a very close relation. Even the doctors used to be considered as the family member because the families were not taking any decision without the help of the doctor.
Yes.
Then what happened? They were having, and what fees they were getting? Somebody was bringing 5 kg of the milk. Somebody was bringing this. But the relations were very nice. Then what happened? Sir? Then they started, the insurance companies came. Because, well, doctor, you are saying 40%, 30 patients every day, and you are not charging anything. You keep on seeing the patient, and we will charge the money for you. Okay, sir. Then doctor became little greedy. Yaar, sala acha hai, humko udhar se paisa mil jayega. So they started taking. And after that, the corporate peoples came, corporate hospitals came. The corporate hospitals came and they told, well, Dr. Gupta, you are so intelligent, you are having so much clientele. How much you are earning? Sir, I'm earning about 4 lakh rupees per month. Sir, why you are wasting your time? I will give you 10 lakh rupees per month. You come and join my organization. They started joining. Here again the greed came, and our Hippocrates sitting in the heaven started crying. I never gave this message to the doctors community. And after that, what happened? The pharma companies came. Pharma companies also maligned their community. And ultimately, which I have spoken about 4 years back. And ultimately, the artificial intelligence will be managed. Corporates will bring the artificial intelligence, and all the superior doctors will be asked to sit in the house. So that day is coming. And one more thing I would like to comment over here. What is going to happen about the medical negligence? If, by the way, machine is doing some negligence, who will be blamed? At least the doctors will be saved from that.
Dr. Rai, I was coming to that because ultimately, if there is harm or there is a medical negligence, of course, this particular system is yet to get any legal approval.
Yeah.
Ritu.
Sir, first thing that will come to identify the competence and mistakes made.
Yes.
Now, we hardly do any clinical audit in a hospital. And even if the NHS does a clinical audit, they do for some small thing. Now, I am with TCS advising them to develop a platform for clinical audit, where whole protocols can be entered through AI system, and even a small mistake done by a physician can be diagnosed. So I think we're coming back that the technology can help you to make less mistakes.
It seems that there's a vicious circle.
Actually, Dr. Agarwal,
whatever is best contribution and that is done. Yes.
Most of these AI platform, which we were discussing, they make us sign a disclaimer that these are based on the data and they are excused from any medical liabilities. This is the disclaimer which most of the AI platforms are making us sign. I mean, this was a point discussed.
I wish individually Dr. Ashok Gupta hai or Dr. Arun Agrawal or Dr. Jamkar could make it.
The problem, sir, the problem will be, as we have already discussed, that 20% services are being catered by the public sector and 80% by the private sector. The EMR is not there. The best data which the public sector is having, they are not sharing and they don't have the digital. Again, we will be lacking somewhere. So as far as we are discussing about the infrastructure, I 100% agree with you all, sir. Until unless we are not having the superior infrastructure, the things we will have to face in the future also. Very rightly, sir.
I think, is Ritu there? Dr. Kalra, our legal expert?
नहीं, इरा आज नहीं है.
अच्छा.
हाँ, ये चीज उसमें रह गई है क्योंकि लीगल अभी तक अप्रूवल. Last time I also asked which is the appropriate authority to regulate this AI. Whether it is a telecommunication in a ministry or is a health ministry or a. Who will regulate?
All these gadgets need to be approved by FDA.
FDA means Drug Control Department. In India, it is Drug Control Department.
The kiosk which I showed is manufactured by a company called India Health Link, and which has been approved by FDA US.
Yeah.
Every gadget they are putting on point of care devices has to be approved by FDA.
FDA, yeah. So Indian FDA definitely will take this. I'm not sure what are they doing. What is their thinking on that?
Point is, Dr. Kalra, I want to raise, approved by FDA, but the legal liability, because it's a clinical, will probably lie with the regulatory body like NABH or MCI or a National Medical Commission, because it involves the doctors and it involves the hospital infrastructure where NABH is responsible for approval of this. So it's a
even our eye doctor
control.
Will not prescribe. Prescription has to be validated by a doctor.
Yeah, I mean, it's a multi-agency.
I think this particular discussion may continue, but now we are approaching, or we are already through 12 o'clock. The only, with your permission, Dr. Kalra, if I give the last remark and then hand it over to you. I think we know it very well that the medicine is never 2 + 2 = 4. And we all have to understand, Dr. Roy, that this formula has to be understood by the legal system also. And they understand it very well.
Yes.
But at the same time, we cannot do without technology. And the technology in terms of AI is the one which will definitely help us in bringing accuracy and dealing in bulk. Yes. We, in Indian scenario, we have to reach our community in such a way that ultimately either we have that much manpower that, okay, I will look after each and every village, each and every family. If answer is no, then can we develop a technology so that at least deeper penetration is there for screening, and then we can definitely select out and bring the person for treatment. So the role of AI is developing very fast. And Dr. Jamkar, you have given a wonderful review of what all happening in India and all over the globe. Let us try to bring, but the outcome has to be correlated with the best possible clinical acumen so that it becomes 99% accurate, if not 100%. जैसे medicine में 100% कोई चीज नहीं है, तो 99% तो we have to bring the accuracy. With this aim, we will like to encourage. India is one country where I always say, Dr. K.K. Kalra, I must have told you this sentence, the numbers are so big, the unfortunate suffering of such a big number become fortune for medical education, for research, and for development of technologies like AI. So let us utilize our unfortunate situation of big numbers for the best possible. India can contribute maximum possible. एक छोटा country क्या contribute करेगा? It's all number game, Dr. Jamkar.
Yeah.
For development of AI, it's all number game. Whether we are able to contribute 5 lakhs X-ray chest or 10 lakhs or MRI, more and more, perhaps the accuracy will be more. With these remarks, thank you, Dr. Jamkar. Thanks all my colleagues for sparing and contributing. Back to Dr. K.K. Kalra and Saurabh.
Thank you, both the Aruns, today for wonderful discussion and the session. And definitely the use of AI is very, very important, essential, but definitely we need to first strengthen our infrastructure as well as the human power. We cannot ignore the human force. Definitely AI should be used with the objective to make healthcare more accessible, affordable, and timely to all kind of society, whether it's a rural or urban. And definitely we must work towards AI, but a balanced approach definitely is required. We cannot replace a human with the total AI machines. Definitely as on date, till we are able to get some more requirement needed as there is as a date. There's no clarity on the regulation part on these AI devices. So it's a very good insight. Definitely we should work for use of judicial use of AI so that quality care is available to all the masses in our country. I thanks and conclude the session today with these remarks. And see you next 2 weeks. I will not be available. I will request Saurabh to be coordinating with you all and to have these meetings. Thank you. See you.
Thank you.
Before you end, Dr. Kalra,
Yeah.
I just want you to request everybody to submit their biodata or maybe brief bio sketch so that we understand which internet people we are discussing.
So once I come back, I will do that. Yeah.
Okay, no problem. Thank you.
Before closing, wish all a happy Independence Day in
Yes.
advance.
Thank you. Thank you, Doctor.
Yeah.
Yeah. Thank you.
Thank you.
Thank you, sir.
Bye.
Thank you.
Thank you.